Hello guys, I'm Dr. Sonali Jagati, Senior Resident Obs and Gynae at SCB Medical College and Hospital, Cuttack, having secured an all-India rank of 3546 in NEET PG 2021. Today, I have come with a very important topic discussion, that is thalassemia screening as per the Fogsi 2025 guidelines. So in this video, we shall be discussing about every point of how do you screen, when do you screen, how do you interpret a HPLC report, which I find many postgraduates finding it very difficult, and as residents it is confusing. What time you should screen and how do you make it very effective, and what are the further plans when you have to counsel a patient with thalassemia. So let's get straight into the topic. So today let's discuss about universal screening for thalassemia and hemoglobinopathies as given by Fogsi as per the guidelines of Fogsi issued in the year 2025. So they have made certain important practice points for universal antenatal screening for thalassemia and hemoglobinopathies. Very importantly, you should remember, hemoglobinopathy carrier screening must be offered to all previously untested women, irrespective of identifiable risk factors. This is very important point to remember. So any antenatal female who comes to our OPD who has not been screened earlier has to be offered hemoglobinopathy carrier screening. If preconceptional screening has been not performed, testing should be conducted early in pregnancy, preferably at the first antenatal visit and before 8 weeks of gestation, to facilitate timely fetal diagnosis and informed reproductive choices. Remember, it's a level A class 1 type of evidence that they have given. Both partners should preferably be screened simultaneously to ensure optimal reproductive decision making. This is also very important to remember. Expert panel strongly recommends strategy combining universal screening, accurate carrier identification, genetic counseling, antenatal diagnosis to be an effective strategy to reduce thalassemia related morbidity and disease burden. So it is combining the screening, carrier identification, then as an obstetrician you have to do the genetic counseling. Maybe you can refer them even to a fetal medicine expert, and also doing the antenatal diagnosis at the right time is an effective strategy to reduce the burden of thalassemia. HPLC, the definitive technique of choice. So how do you screen it? It's definitely HPLC, and it is strongly recommended provided screening has not been done earlier. Of course, if she has done previously HPLC, you do not have to repeat it. And this is for detecting carriers of beta thalassemia and other hemoglobin variants like HbS, HbE, HbD. Okay. During screening, remember that it should always be done at the first antenatal visit, preferably in the first trimester, and the at-risk couples who are identified should be provided access to prenatal diagnostic testing and genetic counseling early in pregnancy. This early timeline is essential for several reasons. Suppose a pregnant woman is carrier, her partner should also be screened to assess the risk of having a child with thalassemia major. In cases where both partners are carriers, confirmatory fetal testing through chorionic villus sampling, that is CVS, should be offered between 10 and 14 weeks of gestation. This timeline allows at-risk couples to receive necessary information well before the 24-week legal limit of medical termination that we know, the MTP amendment of 2021, that she can undergo MTP only up to 24 weeks. Okay, so this is important that this timeline should be kept in mind while screening and diagnosing partners for thalassemia. Consideration of limitation of each screening method is crucial. Infants screening enables early detection of sickle cell disease and also severe forms of thalassemia. Adolescent screening allows for identification of carriers prior to partner selection during marriage, and this is also a very important thing. And many educated and informed couples also try to, not couples, basically when they're planning for marriage, they come for thalassemia screening, which is a very good step. So before marriage, they try to screen themselves for thalassemia or other hemoglobinopathies, so that they can have a well-informed decision making in the future. Screening of young adults enables carriers to make informed decision prior to marriage. This is the same thing again. Okay. Now, important question is that why have they chosen HPLC over other methods? So your red cell indices like MCV, MCH and Menzer index alone are insufficient for definitive thalassemia diagnosis due to low specificity, okay, especially in population with overlapping iron deficiency. So we know that most of our female, they have iron deficiency anemia. So and we know both thalassemia and iron deficiency anemia have a microcytic hypochromic picture. So it is important to differentiate between those two, thalassemia and iron deficiency. So using alone MCV, MCH and Menzer index will be insufficient, and HPLC should be used as a confirmatory test given its superior ability to detect the hemoglobin variant and also quantify the HbA2, HbF as recommended by national and international guidelines. Okay. Of course, considering the fact that HPLC test may not be available in every setting, considering that our country has low resource settings, so we should also know that there are other tests and what will be their limitations over HPLC. So we have the Nestrov test, okay. It can have false negative results in small proportion of beta thal carriers, and hence it's not recommended. CBC based red cell indices, as I have already told, atypical beta thal carriers may show normal MCV or MCH, okay, and carriers of HPS like HPE, HPS may have normal indices also. Capillary electrophoresis is not extensively evaluated in India, and cellulose acetate electrophoresis, the lab should have adequate experience with this technique, and it's time consuming and cumbersome. So first I'll just tell you this important flowchart that has been given by the guideline. This is the pathway for screening or diagnosis of thalassemia in adolescent and young women, preconceptionally, pregnancy and neonatal population. Okay, so we are interested about preconceptional and pregnancy more. So let's understand that. Preconceptionally, couples planning pregnancy or undergoing premarital counseling and preconceptional screening, essential for all couples coming to infertility clinic for assisted conception. So even if a couple is coming for any ART procedure also, you should screen them for thalassemia as well. So as we told, the investigation of choice is HPLC, that is high performance liquid chromatography. So you can quantify the hemoglobin variant. When the HbA2 is more than 3.5, okay, let's just use another color, okay, more than 3.5%, it is diagnostic for beta thal trait. Elevated HbF, that is fetal hemoglobin, suggestive of beta thalassemia or hereditary persistence of fetal hemoglobin. If you see HbE, HbD, HbS peak, identifies other hemoglobinopathies. So there can be HbE variant, HbD, HbS, like in sickling. If HPLC is normal, then routine documentation. Okay. So in this way, you are going to further counsel. so you have to do, if she's a young woman, adolescent with HMB, then you have to counsel her regarding what are her future course of this disease and where she should consult hematology, and also keep these records which are very important for her future pregnancies. Complete blood count and analysis will show MCV less than 80, that is microcytosis, hypochromic, MCH less than 27, Menzer index less than 13, such as thalassemia trait. This is important, and this is the way you will differentiate it from iron deficiency anemia, where the Menzer index will be greater than 13. So remember, less than 13 is thalassemia. Okay, you can remember the mnemonic LT. Okay, like your lecture theatre. Less than 13 is thalassemia. Any values that are abnormal, or if there is any family history, you have to proceed to HPLC. Okay, now this is important for us, that pregnancy, you screened her during the first antenatal visit, and if the couple has come carrier for the hemoglobinopathy, you have to do the gene mutation analysis. Gene is identified, offer prenatal diagnosis. 11 to 14 weeks you are going to offer her CVS under the ultrasound guidance, and then you have to depending on the report, you have to counsel them regarding continuation or discontinuation of pregnancy and appropriate intervention and follow-up counseling. If she comes after 16 weeks, you have to do amniocentesis. Amniotic fluid can be analyzed directly by HPLC, and after ensuring there is no maternal contamination. This is important. Very important tactical strategy that the government, like through Fogsi, has mentioned, that this awareness and advocacy of universal screening is recommended. Rolling out universal screening in low resource or rural settings is required, but for this, training is required in all community and facility based healthcare workers. So at the grassroots level, we have to ensure that our healthcare team, like the workers which include your ASHA, ANMs, Anganwadi workers, the technician, medical officers, everyone should promote and educate the female regarding the couple regarding the screening, and also there should be widespread use of the digital tools. Now comes the most important part, that how will you interpret the HPLC. So samples with hemoglobin greater than 8 and red cell indices showing MCV less than 80, MCH less than 27 is screening positive for beta thal trait, and they are taken up for confirmatory screening by HPLC. So this is when you do a CBC, and this is what you get, and then you will suspect that whether she is having thalassemia or no, because you have to confirm it now. So beta thal trait, that is the carrier state, is identified by elevated HbA2 levels, that is more than 3.5%. Okay, however, iron deficiency anemia may lower HbA2 levels and may mask the carrier status also. So that's why you should also do an iron parameter study like ferritin. Despite this, HbA2 levels more than 4% remain highly suggestive of true carriers. So that's why in any anemic patient, we generally perform the entire iron profile along with HPLC. It's never an individual test, especially if you're working in a tertiary center and you have the facility to do the test, then it's always advisable that you perform all the tests for the anemia line, because it will avoid any overlapping or confusion with the report as we have discussed. Beta thal major, in this the HPLC will show absent or markedly reduced HbA, that is adult hemoglobin, will be markedly reduced. Okay, it may be even absent, and significantly elevated HbF fraction with mean HbF levels exceeding 60%. So they have given an average cutoff of 60%, above which you will find the fetal hemoglobin. It is indicative of beta thal major, where A production is completely suppressed. There can be even compound hemoglobinopathies, which we usually find in the reports also. That is, there is co-inheritance of structural variants such as hemoglobin E or hemoglobin D with beta thal producing overlapping red cell indices and complex HPLC pattern. necessitating careful chromatogram interpretation, and even sometimes you may require molecular confirmation. You have HbH disease, that is alpha thalassemia. Okay, in this you can have HbH or HB Barts, which are diagnostic of HbH disease associated with 3 gene alpha globin deletion. So these are some rare variants, but you should know. Compound hemoglobinopathies you will find sometimes in your patients. We also see in our routine HPLC reports that they don't come with pure beta thal major. They'll have some compound hemoglobinopathies. They'll have some variants like HBE or HBD. Okay, they'll have some complex HPLC pattern. So this is important. So along with beta thal, they will have these structural variants also. Then there's something called as borderline HbA2. That is, we saw that for carrier state it was more than 3.5. Borderline is 3.3 to 3.9. They are telling, where it is diagnostically ambiguous and may require confirmation with molecular testing. Persistence of fetal hemoglobin hereditary. So HbFH, okay, delta beta thalassemia and HB Lepori syndromes may present with disproportionately high HbF levels in absence of significant HbA2 elevation, aiding in differential diagnosis. So this is very, very important. Some rare forms although, but we are supposed to know. So they have just told in a very tabular fashion that the hemoglobin normal, which is adult type, has alpha 2 beta 2, and it should start predominating by 3 months of age. It's usually only 20 to 30% in the term baby, and it should start increasing, or it should be the major type of hemoglobin by 3 months of age, but it becomes low or absent in case of a thalassemia major and in sickle cell anemia also. A2, that is alpha 2 delta 2, should be only 3.5% in adults, but when it's more than equal to 3.5% HbA2, it is diagnostic of beta thal trait. It's more than 4%, there is mild. If it's more than 8%, it's Lepori. More than 15%, it can be HbE trait. Fetal hemoglobin, that is alpha 2 gamma 2, should become less than 2% by 6 months of age. But if it is very high, then it is beta thal major, as we saw. Okay, this is very important diagnostic criteria for beta thal major. Other hemoglobin types like S, D Punjab, E, H, these are absent in normal individual. The present indicates carrier or disease state like HbE beta thal condition. So this is how we designate beta thal with HbE. HbE beta thal, that is how it's written in the HPLC report also. HB Barts is your gamma 4, and its presence indicates alpha thalassemia. This can be a cause of hydrops fetalis and HbH disease. This we have covered in a nutshell about every aspect of thalassemia. I hope you found it helpful. If you have any doubts, feel free to write in the comment section. I'll be glad to help. Stay tuned. Bye bye.